Alrighty, so we're gonna get started in just a minute. For those of you who have just logged on, welcome. If you haven't done so already, please make sure that you complete the pre-session survey prior to starting this course, just so we get all of the needs of all of our attendees, and it also is required for any continuing education requirements or certificate of training. So I'll give you a moment to do so. We're gonna go to the next screen where you'll still have the opportunity. It will turn off once the webinar starts, though, that link for the survey. All right, so before we begin, I just wanted to take a moment to go over the continuing education criteria for those of you who are attending to receive CNE credit. So this is a 1-hour course that's approved as a nursing continuing professional development activity by the Northeast Multi-State Division Education Unit, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. It's always a mouthful. So in order to receive your CNE credits, these 4 steps must be completed. If you haven't already done so, please complete that pre-session survey. I'll have Abby put it in the chat again, in case you all need that link. If you haven't done this, do this now because it does close when our session starts. Step 2 is to attend the live training. Step 3, you must complete the post-session survey, and that will be emailed to you tomorrow. If you are looking to obtain nursing CNE specifically, you do need to take that extra step 4 and go ahead and take the post-session quiz that will be emailed to you tomorrow as well. So certificates of training, EMS, continuing education, dental IPC, anything like that, steps 1 through 3 are required. However, if you are doing that CNE credit, you have to do step number 4 as well. I just want to take a moment and thank our Project Firstline partners, particularly the COVID prevention field team. So this course was a collaboration with the COVID prevention field team, CPFT. So they've gone out to quite a few facilities in Rhode Island and saw some common trends and needs for education in a few areas within the environmental services departments. So I do believe CPFT is such a great resource that originated with the COVID-19 pandemic and has proven to be a valuable asset to the Department of Health, and a resource to our communities. So I went ahead and read their bio in part 1 on Monday, so I'll refrain from doing that today. However, if you feel as though your facility would benefit from either preparation education and training or outbreak assistance, please reach out to the CPFT via the link that I will have Abby put in the chat, and you can request assistance. So again, welcome. My name is Allison Thurber, and I'm a public health nurse at the Rhode Island Department of Health and a training liaison for Project Firstline Rhode Island, and I will be hosting today's webinar, EVS Deep Dive Part 2. For today's webinar, please feel free to place any questions that you have in the Q&A box in the navigation below the presentation screen or above, depending on your preference of how you have your Zoom set up. Dr. Kearney, our medical director, and I will be answering all your questions at the very end of the webinar. So I would like to invite Dr. Kearney to kind of pop in and say hi. She'll be here for the duration of the webinar and again to assist with any Q&A at the end.
Good morning, everyone, or I guess good afternoon now. We're excited to have you all here with us. Please let us know if you have any questions or how we can best support you in your EVS adventures.
Absolutely. Thanks, Dr. Kearney. So lastly here, there is a chat box function that you've seen us put links in as we've gone along so far. That can be used to introduce yourselves and where you're from. You can reply to any interactive slides and communicate with the fellow attendees and our team. We'll be placing some links as we go along still and resources in the chat box as the webinar moves along. But if you do miss them, don't worry because we will send out post-session resources that include all the links from today's session as well. So this is quite a jam-packed session, so let's get started. So I'm just going to start with the agenda, introductions, learning objectives. We're going to go over cleaning and disinfecting surfaces and patient areas. It's very broad, but we will get into detail here, and maintaining cleaning and disinfection processes. Cover key takeaways, resources, references, end of session feedback, all our usual stuff, and then we'll have time for Q&A. Session objectives for today are to be able to identify and disinfect surfaces that are considered high touch, Understand how to clean and disinfect surfaces within the healthcare environment, including occupied and unoccupied spaces. Understand how to integrate the core components of cleaning and disinfection in your facility EVS program. And know how to use the EPA website to look up safe and effective products for cleaning and disinfection. So some key terms we will use throughout the webinar today to be familiar with. EVS personnel or EVS technicians, you're responsible for cleaning and disinfecting of reusable equipment and environmental services and patient care areas. They can be directly employed by the healthcare facility. They could be a contracted staff or another management structure. Additional healthcare providers are also often responsible for cleaning and disinfection, like CNAs or nurses, for particular roles. Then we have safety culture. Safety culture of an organization is the individual and group values, attitudes, perceptions, competencies, and patterns of behavior that determine the commitment to health and safety management of a facility. We have non-critical environmental surfaces. So those are surfaces that come in contact with skin that's intact, not mucous membranes. So that includes surfaces like bed rails, bedside tables, countertops, patient furniture, floors, things like that. And then we have reusable patient care equipment that are devices that healthcare providers can use to diagnose and treat multiple patients, like surgical forceps, endoscopes, stethoscopes. We have routine cleaning, and that is the regular cleaning and disinfection when indicated when a room is occupied to remove organic material, reduce microbial contamination, and provide a visibly clean environment. Emphasis here is on surfaces within the patient zone. And then a terminal or discharge transfer cleaning is just what it sounds. It's cleaning and disinfection that's performed after the patient is discharged or transferred. Includes the removal of organic material and significant reduction and elimination of germ contamination for the next patient that's going to be, utilizing that room. All right, so let's jump right into cleaning and disinfecting surfaces. So to piggyback off of CDS Part 1, I would like to stress the importance of the role EVS staff play in infection control and prevention. So that includes on-the-ground EVS staff leadership, admin, those who take part routinely in cleaning, disinfecting, and sterilization. So it's imperative that cleaning and disinfection practices are infused into the safety culture of a facility and that staff recognize the importance of their work to prevent infection. So the diagram showed here depicts how cleaning and disinfection can stop the spread of infection, and without proper cleaning and disinfection, how infection can spread. So here you can see a colonized patient or infected patient can contaminate environmental surfaces and non-critical patient care equipment. Microorganisms from these contaminated environmental surfaces and non-critical equipment can be transferred to a susceptible patient in two ways. First way is if the susceptible patient makes contact with the contaminated surfaces, so touching it directly. You touch a bedside table and that has germs on it, and then you get that infection. Second way is if a healthcare personnel, caretakers, or visitors make contact with contaminated surfaces and then transfer the microorganisms to a susceptible patient. Contaminated hands or gloves of healthcare personnel, caretakers, or visitors can also contaminate environmental surfaces. So the combination of proper hand hygiene and environmental cleaning can prevent transfer of these germs or microorganisms to healthcare personnel, caretakers, visitors, and to susceptible patients. And in the screen in front of you, you can see where environmental cleaning and or glove removal and hand hygiene can break that pathway of infection. So high-touch surfaces. High-touch surfaces are surfaces in a facility that are frequently handled by patients and staff. And these surfaces need special attention to cleaning and disinfection because of their ability to spread infection based on how many people touch them. They're commonly shared surfaces. So these can include bed rails and controls, overbed tables and controls, handles on the bedside, light switches, toilet seats, flush handles, sinks in the room and the bathroom, hall lights, the list goes on and on, phones, doorknobs, all of that. High touch surfaces, they're commonly touched by multiple people. So here we can take a minute and pause. We have a picture of a room. Looks like maybe like a blood drawing cart. A few other things and some staff in the room, occupied patient room. What are some examples here that you would consider high touch surfaces? If you feel comfortable, you can go ahead and just put some answers in the chat there. But after just talking about high touch surfaces, what do you see in this picture that would be considered high touch? Med cart, bed rails. Yeah, there's most things in this picture I feel like are high touch. So you see the laptop, the sides of the bed, the sink faucet, the handles on the faucet, the door handles, the bedside table, if I didn't say that already, bed rail, most, a lot of the things here that you're looking at are high touch. And these are surfaces that are touched by multiple people and have the capability of transferring germs from one patient to another, or patient to staff, patient to visitors. Okay. So cleaning and disinfecting these surfaces. We just identified these high touch surfaces together in a healthcare setting. So then how does staff go about cleaning and disinfecting them? So let's go over some key points about cleaning and disinfecting, specifically high touch surfaces. It is important to include identified high touch surfaces and items into checklists as administration and other job aids to facilitate comprehensive cleaning procedures, so that your staff know what is expected of them and the surfaces that they need to reach. So here, if blood or body fluid is present on a surface, it must be removed prior to disinfecting. So there are disinfectants that also clean, and they're like a 2-in-1. However, if there is gross material on a surface, that gross material needs to be removed first prior to any cleaning or disinfecting happening. So make sure you're doing that. You're not just using a cleaning and disinfecting one-step product. You have to remove, whatever contaminated materials are on that surface first. Then you can go ahead, check the label, see if instructions indicate that cleaning and disinfecting can occur in one step once those gross materials are removed. And always use a freshly prepared solution. So here we have the CDC recommended general surface cleaning and disinfection process. Basically goes over how to fold a cleaning cloth and appropriately clean from top to bottom. So one, you're going to thoroughly wet soak a fresh cleaning cloth in whatever environmental cleaning solution that you're using for the surface. Fold the cleaning cloth in half till it's about the size of your hand. That way you ensure that you're using all the surface area on your hand efficiently. Usually if you fold it in half and then in half again, you'll have like 8 sides that you can use. Wipe surfaces using the general strategies known to cleaning and disinfecting. So that's clean to dirty, high to low, and systematic. And we'll go over that again before this webinar ends. But again, clean to dirty, high to low, and in a systematic manner so that you know where you're going and you don't forget or miss spots. Make sure to use mechanical action for cleaning steps, so scrubbing, and make sure that the surface is thoroughly wet to allow the required contact time. So we did go over this in the first part 1 webinar, but contact time is the time that a surface must remain wet in order to do its job to clean and disinfect that surface. Not just stay on the surface, but it must remain there visibly wet. So if that time ends up, how can I word this? If the surface dries out before that contact time is up, then you would need to reapply the cleaner or disinfectant in order for it to do its job. You want to make sure that you're regularly rotating and unfolding the cleaning cloth and using all sides of it. When all the sides of the cloth have been used, or when it's no longer saturated with solution, you want to dispose of the cleaning cloth and store it for reprocessing. And then you would repeat the steps as you need with more cloths. So we just covered how to clean and disinfect a surface. And now here we have CDC recommended best practices for cleaning and disinfection. So this includes using fresh cleaning cloths at the start of each cleaning session. So example would be like routine daily cleaning in a general patient ward. Change cleaning cloths when they are no longer saturated with solution for a new wetter cloth. Soiled cloth should be stored for reprocessing. For higher risk areas, change cleaning cloths between each patient zone. So use a new cleaning cloth for each patient area or bed. And then for example, like if you have a multi-bed intensive unit, then you'd use a fresh cloth for every bed or incubator. And we do have on the CDC website guides for specialized patient areas. So ICU, ED, OR. We're not getting into it in this webinar. It would just be much too much to put into a webinar and much too specific. But CDC does have those resources on their website, and we'll put those in the post-session resources for you as well, if that is something that your facility has. Ensure that there are enough cleaning cloths to complete the required cleaning session, and never double dip cleaning cloths into portable containers like bottles or small buckets used for storing the cleaning products. Never shake mop heads and cleaning cloths, as that will disperse the dust or droplets that contain microorganisms, and also never leave soiled mop heads and cleaning cloths soaking in buckets. So next we'll go over the key steps to cleaning and disinfection, and we will cover 4 areas specifically. First, we'll just go over general, and then we'll go over outpatient area surfaces, routine cleanings, terminal cleanings, and scheduled cleanings, and all of those are for inpatient settings. So in general, it's important that no matter what setting you are cleaning or disinfecting, it's important to keep in mind these key techniques. So first, you want to make sure you're conducting visual preliminary site assessments. So you're assessing for patient status that could pose a challenge to safe cleaning, the need for additional PPE or supplies, any sort of obstacles you see in your way of cleaning, and damaged or broken surfaces. Second, you want to make sure that you're proceeding from clean to dirty. So you're going to clean from low touch surfaces to high touch surfaces, which should be, again, cleaner to dirtier. And you'll clean patient area rooms before you clean bathrooms, for example. You'll start with common areas and equipment, moving to items that are touched by patient care team themselves, and then to the patient themselves. And then make sure that you're cleaning areas that are under transmission-based precautions after those that are not under transmission-based precautions. Number 3, you want to make sure that you're proceeding from high to low. So cleaning from high to low prevents dirt and microorganisms from dripping or falling on surfaces that have already been cleaned. So if you're cleaning a wall, if you clean the bottom and then you go ahead and you reach the top and then it drips down, you've contaminated the bottom, right? So you want to make sure you're doing the top first and then you go ahead and get the bottom. You want to make sure that you're proceeding in a methodical, systematic manner so that you make sure that you are not missing any areas. For example, every time you clean a room, you go left to right or clockwise or counterclockwise, depending on, how the room is set up and your preference there. And also, we want to make sure that we're immediately attending to body fluid spills and that we're not leaving them for someone to accidentally contaminate themselves. Or for general cleaning, we don't want to leave it for like a regular cleaning. We want to clean it right away. So just as we spoke about, here's an example of cleaning from clean to dirty. So let me get out my pointer. Okay, so on this side here, we can see that you go from the outside in. You want to start cleaning with shared equipment and common surfaces. Then you can move along to items touched during patient care, which would be, considered a little bit more dirty. And then you would move to patient and direct contact items. So if a patient does have, if they're colonized or if they do have an infection and they're touching things, that those items that are most dirty are cleaned last so that you're not going backwards and inadvertently contaminating surfaces that have already been cleaned. So then we have here a systematic way or an example of how to clean a room. Obviously, every room is going to be different based on your facility. You have different furniture. You have one bed patient rooms, two bed patient rooms, four bed patient rooms, maybe shared bathrooms, unshared bathrooms. So everything will be different, but based on where you're cleaning, make sure that in your head you have a systematic way of going through the room so that you don't forget certain spaces. Here you can see that there's kind of like a clockwise movement. And then of course, you want to do the bathroom last because that's the dirtiest. All right. So getting to all of our different settings, we can start with an ambulatory setting, minimal cleaning recommendations. So we made this handy chart. This will be included in the post-session resources. You don't have to memorize it. We'll just go through it quickly. But for scheduled cleaning of ambulatory settings, we do recommend, or CDC recommends, cleaning the waiting admission room daily. You're going to do high touch surfaces and floors, and consultation examination rooms twice daily. Same thing, high touch surfaces and floors. For any procedural, like minor operative procedures, suturing wounds, draining abscesses, things like that, you want to do that before and after each procedure, and then at the end of the day. So you'll do high touch surfaces, emphasis on like the patient zone, procedure table, and then at the end of the day, you want to make sure all the surfaces, floors, hand washing sinks, and like scrubbing areas are all taken care of. Then all other areas, make sure that you have a scheduled cleaning frequency, and when they're visibly soiled, that would be for like low touch surfaces. Then we have routine cleaning. So a routine cleaning is regularly scheduled cleaning when a patient's room is occupied during their stay. Routine cleaning of inpatient areas occurs while the patient is admitted, focuses on the patient's zones, and aims to remove organic material and reduce microbial contamination to provide a visually clean environment. So this is recommended to be done once daily per the 24-hour period. You'll clean the high touch surfaces and floors and hand washing sinks, also when visibly dirty. Then on a scheduled basis, for example, once weekly, you want to make sure that you're cleaning low touch surfaces, and we'll go over scheduled cleanings for low touch surfaces in a few more minutes. So then there is terminal cleaning, and that is when a patient is transferred or discharged and the room is being cleaned and disinfected for the next patient that'll occupy that room. So CDC recommends the following steps for terminal cleanings. First, make sure you review and familiarize yourself with transmission-based precautions, special considerations for the room, anything that you need to consider prior to cleaning and disinfecting. Wash your hands with an alcohol-based hand sanitizer or soap and water prior to cleaning. Don necessary PPE. Maybe there are transmission-based precautions listed outside the room, or that the patient was on transmission-based precautions and you would need to don PPE, or maybe you're donning PPE because of the cleaning product that you're using. You would remove soiled, used personal care items like cups and dishes for reprocessing or disposal. Then you would remove facility-provided linens for reprocessing or disposal. You would inspect window treatments. If they're soiled, you would clean the blinds on site, remove the curtains for laundering, reprocess all non-critical patient care equipment, and then you would clean and disinfect all low and high touch surfaces, including those that may not be accessible when the room or area was occupied, like the patient mattress, the bed frame, tops of the shelves, vents, and floors. Then you would go ahead and clean, scrub, and disinfect the hand washing sinks. Again, if there's like a bathroom, the bathroom would be the last part of leaving that room. And then you would mop on your way out. And then lastly, we have scheduled cleanings. And scheduled cleanings occur concurrently with routine or terminal cleanings, and these aim to prevent and reduce the dust and soiling on low touch items or surfaces. So you perform scheduled cleanings on items or surfaces that are not high risk for soiling under normal circumstances, using neutral detergent and water. If they are visibly soiled with blood or body fluids, though, again, they should be cleaned and disinfected as soon as possible and not wait for a scheduled cleaning. So the recommended or the recommendations for scheduled cleanings are weekly to clean any high surfaces. So not high touch surfaces, not to get confused, but high surfaces, surfaces above shoulder height, such as tops of cupboards, vents, walls, baseboards, corners. Again, these are not considered high touch surfaces, but they should be cleaned once weekly to make sure that there's no dust accumulation for patients. And then monthly, you want to make sure you're doing the window blinds and the bed curtains, and then annually window curtains. However, again, if anything is visibly soiled, it should be taken care of as soon as possible. I did mention before, but I'll mention it again, that aside from all of these patient care areas that we discussed, CDC does have specific recommendations for shared toileting spaces, ORs, ICUs, ERs, sterile service departments, labor and delivery units, hemodialysis areas, isolation units, pediatric wards, and other areas with high-risk patient interactions and procedures. So all of these special cleaning and disinfection recommendations are listed on the CDC website at the link that we can provide in the chat, and we'll also provide in the post-session resources. It's also important while following recommendations to be sure that you're following their facility-specific procedures and recommendations for your workplace and the patient population that you serve. All right, so I feel like all of that was a large mouthful, and we are going to shift a little bit from frontline staff, cleaning staff, EVS staff, to how to establish and continue an effective EVS program within a facility. So before you can see the core components of cleaning and disinfection, and we will go in depth and explore each one of these core components. The core components include, integrating environmental services into hospital safety culture, educating and training all healthcare personnel responsible for cleaning and disinfecting patient care areas, selecting appropriate cleaning and disinfection technologies and products, standardizing setting specific cleaning and disinfection protocols, monitoring effectiveness and adherence to cleaning and disinfecting protocols, and then providing feedback on adequacy and effectiveness of cleaning and disinfection. So all of these core components together make up a successful EVS program. So first, integrating EVS into safety culture. We mentioned this a little bit in the beginning, but achieving and maintaining a clean patient care environment is a critical component of a hospital safety culture. So in any hospital, EVS staff plays a pivotal role in IPC and in patient and healthcare personnel safety in the patient care environment. So establishing a hospital cleaning and disinfection program with defined management structure and multidisciplinary participation and oversight is key. This should include representation from hospital leadership, quality, nursing, purchasing, facility management, infection prevention control, and EVS. So there should be regular meetings held to review practices and quality measures and establish and review facility goals. It's also important that that you define the program responsibilities, including but not limited to evaluating effectiveness of the program, establishing and maintaining a clear reporting and accountability structure. And it's important that you develop a performance evaluation and career advancement structure for EVS personnel and management that encourages excellence, rewards expertise and skills, optimizes retention, and incorporates considerations for effective cleaning and disinfection into the design, structure, and layout of the patient care areas specific to your facility. Next, it's important to make sure you're educating and training all healthcare personnel responsible for cleaning and disinfecting patient areas. So all personnel who clean and disinfect patient areas must understand their roles and responsibilities. So this is critical for ongoing success of cleaning and disinfection programs and for protecting the health of healthcare personnel, patients, and visitors. So because many healthcare personnel are responsible for cleaning and disinfecting usable patient care equipment and environmental services in patient care areas, appropriate education and training is required for a broad range of staff. So you want to focus the education and training for healthcare personnel responsible for cleaning and disinfection on learning hospital cleaning and disinfection policies and following them, understanding the basic concepts of germs transmission, and recognizing the impact of their work on a day-to-day basis. You want to make sure they know how to protect themselves by using proper PPE and having the effective training so that they feel comfortable and safe in the use of chemicals and cleaning technologies in your facility, and that they understand infection control risk, including sharp safety and other aspects of worker safety as appropriate to the setting or the situation. It's important that all staff are trained upon hire, but then at least annually, and also when introducing any new equipment or protocols. It's important to keep record of training completion and be sure to retrain to address any weaknesses discovered during routine monitoring activities or audits. And if your facility does utilize contracted services for cleaning and disinfection, make sure that the contracted agencies have trainings that meet your facility requirements as well. Lastly, you want to make sure that you're holding competency-based trainings that account for staff turnover, education levels, language and cultural barriers, and multiple learning styles. Be sure to update the EVS management and personnel on trends in the facility infection rates and prevention priorities. A lot goes into the education and training to make sure that staff are safe and feel comfortable in their role. So number 3, we want to make sure we're selecting appropriate cleaning and disinfection technologies and products. So making sure that cleaning and disinfection technology and products are tailored to your setting and standardized as much as possible. You want to use a systemic process to select technologies and products, convene all stakeholders in the decision-making process for factors like compatibility with device manufacturers' instructions, contact time, possible health risks, effect on the surface or devices of repeated exposure to a product, and acceptability to healthcare personnel and patients, effectiveness in decontaminating a surface, all things like that. Facilities should aim to minimize the amount of cleaning and disinfection products that they do use. So a minimum number of disinfectants that are effective against a broad range of pathogens is more effective than a large array of products. This approach aims to simplify which product should be used for what surface and help staff retain specific contact times, product knowledge, and just comfortability with the products. So in the United States, we do rely on the Environmental Protection Agency, the EPA, to review the chemicals that are used in the workplace to make sure that they're safe and effective. Disinfectants used in healthcare should be registered with the EPA, and the label usually says something like hospital grade to indicate that the product can be used in a healthcare setting. So we are going to do a quick little run through of how to look up a cleaning and disinfecting product on the EPA website. So for this example, we want to know if this product here is specifically effective against coronavirus. So I chose a pretty common disinfecting wipe that we can look up together. So let's check this out. So is this product effective against coronavirus? You would go to http://ordspub or the link that you see here on the screen, and Abby will also put in our chat. And that will bring you to the correct page for EPA registration number searches. Otherwise, you can just kind of like do a little Google search for how to look up the product in the EPA system. It can bring you to it. So you are going, let's get out my pointer again. So if we're looking at this product here, these disinfectant, nameless wipes, there will be an EPA registration number either on the front or somewhere on the label of the wipes, right? And the EPA registration number is what you're going to type into the search box on the pesticide product and label system page. So here we have EPA registration number 777114. When you do that and hit search, the next screen will show you all of the quote unquote pests or germs that the product is effective against. So here you can see avian influenza, Campylobacter, coronavirus, fungi, Hep B, the list continues. So to answer our original question, yes, this specific product is effective against coronavirus. EPA website also gives you the ability to do like a reverse search So if you are looking for a product that cleans for a specific germ, then you can do a reverse search and look up the germ, and then you can find a product of a list that cleans for that. So you can do it either way. So back to the remainder of our core elements of an EVS program. The next core element is standardizing protocols. Standardized setting-specific cleaning and disinfection protocols. So this includes identifying standardized setting-specific protocols for cleaning and disinfection, including the use of technologies and products. Emphasize that surfaces, including high-touch surfaces, must be cleaned effectively, accounting for differences in room layouts, equipment, and patient risk. Clearly define responsibilities for the cleaning and disinfection of non-critical equipment, shared medical equipment, and other electronics. It's also important to identify who is responsible for cleaning what. For example, some facilities, EVS technicians or EVS staff are responsible for cleaning the IV poles, but the nursing staff is responsible for cleaning the IV pumps themselves. So make sure that these roles are clearly defined and both parties or all parties know what they're responsible for cleaning and disinfecting. Make sure that cleaning and disinfection supplies are easily accessible, so your cleaning cart and patient care areas are adequately stocked. Develop standardized protocols for routine and discharge transfer, cleaning and disinfection for each major patient care room type. So, a standardized protocol for a routine cleaning in an intensive care room when the person is occupying it versus a standardized protocol for a discharge transfer in an intensive care room, or, standard operating room versus discharge operating room, routine emergency department, discharge emergency department, radiology suites, things like that. Make sure that staff protocols are readily available to staff. So all cleaning protocols, and that all staff are aware of what the protocols are. So if you have, for instance, like a minimal cleaning time of 20 minutes for a routine clean, or a better example would be you have a 20-minute terminal discharge clean and you don't have, a nurse manager, asking you when you're going to be done cleaning this room, because the nurse manager knows the minimal cleaning time is 20 minutes. So you can't get another patient up there for at least 20 minutes because it's going to take you that time at a minimum to clean that room. Make sure that all your protocols include appropriate PPE for EVS personnel, processes for routine and discharge transfer cleaning and disinfection, and other patient level factors like wounds or diarrhea. Facility cleaning specific disinfection technologies, products, and methods. Processes for easy identification of equipment and rooms that have been properly cleaned and disinfected and are ready for patient use, so that your facility has, a clean area for certain technologies or equipment and like a dirty area, and that they're separate, dedicated, and clearly labeled. Develop policies and procedures for storage of patient and visitor personnel items, which can make it difficult to clean or properly clean a room. And make sure that EVS team can identify which patient rooms are under transmission-based precautions. So make sure they're clearly labeled. Again, you want to establish minimal cleaning times for routine and discharge transfer cleanings for each major patient care room type. And then align the minimal cleaning times with staffing plans to ensure that effective cleaning and disinfection can be completed. Be sure that others who are responsible for patient flow, such as my example as like a charge nurse, knows that minimal cleaning times are required for these patient care areas, and make sure and enforce that minimal cleaning times, or make sure to enforce minimal cleaning times, and empower your EVS staff to require adherence to the minimal cleaning times. We know that healthcare facilities can be really busy, right? So say you're in an emergency room and you really need to get the patient out to the inpatient floor, but you're waiting for EVS staff to terminal clean one of the inpatient floors that this room is going to, and you're calling them and you're pressuring them like, hey, we really got to get this patient out of here. Can I bring them up right now? your staff should feel empowered to say, nope, we have not met our minimal cleaning time. I'll be done in 20 minutes, et cetera, et cetera. So as part of the EVS programs, we also want to be sure that we're monitoring for adherence. So there are a few different ways to monitor the effectiveness of cleaning and disinfection, which combination of monitoring depends on your facility. So first, you can use checklists for direct visual observation. So those are quick, they're easy, but they're not super thorough since you may miss, unclean surfaces. I'm going to move I just realized I still have my laser pointer on. Second, you can use fluorescent gel markers with UV light. And these are easy, but they do take time before and after cleaning. They're helpful to share results with EVS technicians to improve thoroughness of cleaning, but it doesn't measure the presence of microorganisms. Next, there are ATP systems. So ATP tests are used to verify cleaning methods in a diverse range of industries. ATP is like an energy molecule that's found in all living cells that allows cellular metabolism to take place. So all forms of organic matter contain ATP. And in healthcare settings, there are many forms of organic matter, such as body fluids, blood, and bacteria left on surfaces. This can become a point of cross-contamination between patients and staff, potentially leading to hospital-acquired infections if it's not properly cleaned or disinfected. So the inclusion of ATP hygiene testing after a surface has been cleaned is an essential indication of cleaning efficacy. Some perks, you have really quick results, indirectly measures direct proteins on the surface from microorganisms, but they could be from other sources, including humans. It does not indicate if microorganisms are alive or killed, though, so it's a little bit tricky. So the best methods usually include a variety, a mix of all of these. And then lastly, there are other ways, for example, like direct cultures for microorganisms. These are a little tricky because it requires 1 to 3 days to see if a surface has harmful microorganisms. So if you're testing a room and you're testing it because you want to see if the microorganisms are gone, then you don't want to fill that room for the 1 to 3 days it takes for that culture to come back. And lastly, in our core elements, we want to be sure that we are making sure that all staff feel valued, they understand their roles, they understand their responsibilities. And to do this, it's really helpful to review specific cleaning and disinfection practice expectations and protocols upon hire and during any sort of like annual trainings. Discuss the manner in which their practice will be evaluated. Stress non-punitive nature of this EVS program and the process of, observation and any sort of materials that you use to assess their cleaning and disinfection. Inform them that their good performance will be broadly recognized, so maybe like beyond their department and highlighted within their department for others to emulate. Repeatedly reinforce the importance of their work and make sure they know how it directly relates to the hospital's goals and mission and how it's appreciated by the patients and plays a major role in patient satisfaction within the hospital. I think EVS staff are sometimes more overlooked as not key players in infection control because you just think, okay, we're cleaning and disinfecting. We're not, frontline patient care. We're not the ones, saving the patients or doing the CPR, but really, on the back end, EVS staff are preventing any further infection. And as we know, healthcare acquired infections are an issue. Patients are getting them, and then it's causing, secondary infections to whatever they came to the hospital with, and they're either becoming more sick, causing, more costs, more illness-related issues, or they're passing away. So truly, EVS staff do play a very, very important role that sometimes goes unrecognized, but hopefully, through a successful EVS program, you can really show your staff that they are valued and respected and very important in the infection prevention and control process. So we covered a lot today, and these slides will be sent to you following the webinar via email, as well as post-session resources. So some key points from today. High-touch surfaces are areas within a facility that are frequently touched and therefore a common reservoir for germs. When cleaning a patient's surface or space, when cleaning a patient's space, it is important to disinfect from clean to dirty and high to low to avoid contamination. Also, you want to go in a systemic way. Facility disinfectant choices set precedents for ease, effectiveness, and safety of all involved in the cleaning process. It is required to use EPA-registered disinfectants within the healthcare setting, and continuing education, refreshers, and job audits and aids are key to preventing harm and increasing effectiveness for EVS staff. Quickly again, I just want to reiterate our certificate of training steps to be sure that those who are looking to get continuing education or certificate of completion have all the resources that you need. So please reach out to our team if you do have any difficulty with any of these steps. We would be happy to help. You want to make sure you do the pre-session survey prior to this session, attend the live Zoom session. The post-session survey will be emailed to you tomorrow, August 30th, and that closes the 5th of September. Then you will have to do that post-session quiz if you are trying to get your CNE credits. So make sure all those are sent in, and then you'll get your certificate emailed to you September 10th. If you have any issues, please just email us. We'll be happy to help. Here we have all of our resources for you that Project Firstline has. We do have a Project Firstline website where we post all of our live webinars, any news coming up, any like specialty months that we have, like C. diff month and things like that, and anything useful. We do have YouTube, X, formerly known as Twitter, Facebook, Instagram, and LinkedIn. You can follow us on all of these or one of these or whatever you want on social media. We do post about upcoming trainings, any certain announcements that we have. So follow along with us. Speaking of future trainings, this September is exciting. We have a microlearn month. So microlearns, these are 15-minute courses that focus on providing just the need to know information about chosen topics. So they're designed to be used in a clinical discussion, potentially to address like during a huddle or a daily meeting, to help staff feel more secure in knowing what to do in certain situations. For instance, if they come across a patient with a rash or a patient with a draining wound. So we have rash, draining wound, blood, cough and congestion, and diarrhea. And they will all be, I believe, Mondays and Thursdays in September. But again, the dates of the 5th, 9th, 12th, 23rd, and 26th. So join us this coming month for our Microlearn series. They will all be at noontime. These are our references for today's session. And lastly, we do have our end of session feedback. Please be sure to fill this out. It really does help us tailor our sessions to your needs. Let us know how we're doing. If you have any questions or would like to be on our distribution list, or would like to request any specialty sessions or anything for your facility, you can reach out to us at projectfirstlineri.com, or you can email us directly at rido.projectfirstline@health.ri.gov. I will leave the poll up, but I'm going to go ahead to the Q&A screen so you can continue to fill out the poll. But also, if there are any questions, I'll invite Dr. Kearney to join me, and we will address any questions that you may have. Again, please put any questions you have in the Q&A box. I don't see any right now. So if we don't have any questions in a minute, we can just close down the webinar. But I just want to give you a moment if you do have any questions to voice those. I don't see anything. So if we don't have any questions, we can end now. I know that that was a boatload of information. Thank you for sticking with me to the end. If you have any questions, again, please feel free to email us or go to our Project Firstline RI website. We'll be happy to answer any questions that you have. So at this time, we'll end the webinar, and I hope that you have a great afternoon.